Welcome to Oncoverse, where we break down oncology one drug at a time. Today, we're exploring targeted therapy, a true revolution in cancer treatment. Unlike traditional chemotherapy, which attacks every fast-dividing cell in the body, targeted therapy is designed to strike only the cancer cells, sparing healthy tissue. In this video, we'll explain what targeted therapy is, how it works, the main drug classes, real-world examples, side effects, resistance mechanisms, and the latest FDA approvals for 2026. Let's dive into the precision revolution that's changing the way we fight cancer. Targeted therapy is a cancer treatment that acts with precision, focusing specifically on cancer cells. Unlike chemotherapy, which broadly attacks all rapidly dividing cells, targeted therapy is designed around unique molecular features found only on or inside cancer cells. This means normal tissues are largely spared, reducing the collateral damage and side effects typically seen with classic chemotherapy. By honing in on cancer-specific targets, these drugs offer a more refined and effective approach to cancer care. Targeted therapy achieves its remarkable precision through four main strategies. First, it blocks the growth signals that tell cancer cells to divide. Second, it can induce programmed cell death or apoptosis directly within the tumor. Third, it starves tumors by cutting off their blood supply. And fourth, it delivers cell-killing substances directly into the cancer cell using a targeted carrier. Each of these strategies is designed to disrupt the cancer cell's survival while minimizing harm to healthy cells. Let's explore the major drug classes that use these approaches. Imatinib was a breakthrough in targeted therapy, specifically designed to inhibit the BCR-ABL tyrosine kinase. This drug is the cornerstone for treating chronic myeloid leukemia, gastrointestinal stromal tumors, and dermatofibrosarcoma protuberans. With a half-life of about 18 hours, imatinib's effects last well beyond a single dose. However, it's not without risks. Side effects can include heart failure, liver damage, muscle pain, and fluid retention. Because it interacts with other drugs metabolized by CYP3A4, careful screening for drug interactions is essential in clinical practice. As with many targeted therapies, resistance can develop over time. In chronic myeloid leukemia, cancer cells may acquire the T315I mutation in the BCR-ABL gene. This mutation alters the drug's binding site, preventing imatinib from attaching and rendering it ineffective. When this happens, next-generation tyrosine kinase inhibitors are needed to overcome resistance and restore treatment effectiveness. Understanding resistance mechanisms is crucial for ongoing cancer management. Dasatinib is a second-generation BCR-ABL inhibitor that binds both the active and inactive forms of the kinase. This makes it a valuable option for patients with Philadelphia chromosome-positive chronic myeloid leukemia who can't tolerate or don't respond to imatinib. Dasatinib has a shorter half-life, around 3 to 5 hours, and comes with its own set of side effects, including bleeding, hypertension, low blood counts, pleural effusion, and QT interval prolongation. It's a key player in overcoming resistance and expanding treatment options. Gefitinib targets the epidermal growth factor receptor, or EGFR, also known as HER1. This receptor plays a key role in the growth and differentiation of epithelial cells. Gefitinib is primarily used for non-small cell lung cancer, especially in patients who have never smoked. Side effects can include diarrhea, skin rash, itching, elevated liver enzymes, and rarely interstitial lung disease. By blocking EGFR, gefitinib disrupts the signals that drive cancer cell growth. Trastuzumab is a monoclonal antibody that binds directly to EGFR, blocking the signal before it can reach inside the cell. It's used for advanced or metastatic squamous cell carcinoma of the head and neck, as well as EGFR-positive metastatic colorectal cancer. Side effects include rash, diarrhea, itching, and infusion reactions, which can sometimes be severe. By targeting the receptor on the cell surface, cetuximab offers a different approach to disrupting cancer growth. Trastuzumab is a monoclonal antibody that targets the HER2 receptor, a protein often overexpressed in certain breast and gastric cancers. By binding HER2, trastuzumab blocks growth signals and helps the immune system recognize and attack the cancer. It has a long half-life of about 6 days, allowing for weekly dosing. However, its most important toxicity is a decrease in left ventricular ejection fraction, so cardiac function must be monitored regularly during and after treatment. Lapatinib is an oral HER2 inhibitor, typically used when trastuzumab is no longer effective in HER2-positive metastatic breast cancer. It's often combined with capecitabine or letrozole to enhance its effects. While lapatinib is generally less cardiotoxic than trastuzumab, it can still cause diarrhea, fatigue, heart failure, and QT prolongation. Its oral formulation offers flexibility and convenience for patients needing ongoing HER2-targeted therapy. Angiogenesis inhibitors are designed to block the formation of new blood vessels, a process that tumors rely on to grow and spread. These drugs target the vascular endothelial growth factor, or VEGF, pathway, which is critical for new vessel formation. By interfering with this process, angiogenesis inhibitors can shrink tumors and slow their progression. However, they also carry risks such as bleeding, gastrointestinal perforation, and poor wound healing due to their effects on normal blood vessel repair. Bevacizumab is a monoclonal antibody that inhibits VEGF-A, a key driver of new blood vessel growth in tumors. It's used in combination with chemotherapy for metastatic colorectal cancer, and is also indicated for lung, breast, renal cancers, and glioblastoma. Side effects include arterial thromboembolism, heart attack, stroke, nosebleeds, rectal bleeding, heart failure, proteinuria, gastrointestinal perforation, and wound healing problem. Its broad utility makes it a mainstay in anti-angiogenic therapy. Sunitinib and sorafenib are multi-targeted VEGFR inhibitors. Sunitinib blocks ATP binding to VEGFR2 and also inhibits PDGFR, c-KIT, and RET, making it effective for metastatic renal cell carcinoma and imatinib-resistant GI stromal tumors. Sorafenib works similarly and is used as a second-line option in renal cell carcinoma, as well as for hepatocellular and thyroid cancers. These drugs are dosed in cycles and have long half-lives, offering sustained anti-tumor activity. Bortezomib is a proteasome inhibitor that blocks the breakdown of damaged or unneeded proteins, causing them to accumulate and trigger cancer cell death. It's primarily used in multiple myeloma and mantle cell lymphoma. The main dose-limiting toxicity is peripheral neuropathy, but bone marrow suppression and low platelet counts are also concerns. By disrupting protein degradation, bortezomib offers a unique approach to targeting cancer cells. Rituximab is a monoclonal antibody that targets CD20, a protein found on B cells. By binding to CD20, rituximab promotes the destruction of B-cell lymphomas, non-Hodgkin lymphoma, and chronic lymphocytic leukemia. Side effects can include infusion reactions, fever, hives, itching, low blood pressure, shortness of breath, late-onset neutropenia, and depletion of normal B lymphocytes. It's a cornerstone in the treatment of B-cell malignancy. Immunomodulatory drugs, or MIDS, include thalidomide, lenalidomide, and pomalidomide. These drugs act as cereblon modulators, redirecting the protein to degrade specific targets that cancer cells rely on. Thalidomide also has anti-angiogenic, anxiolytic, antiemetic, and analgesic properties. MIDS are used in multiple myeloma and myelodysplastic syndromes, often in combination with other agents. Their unique mechanism makes them valuable in treating blood cancers. Antibody-drug conjugates, or ADCs, are one of the fastest-growing areas in targeted therapy. An ADC combines a monoclonal antibody with a cytotoxic chemotherapy drug, linked together chemically. This creates a guided missile that delivers the chemo directly inside the cancer cell, sparing healthy tissue. Examples include trastuzumab deruxtecan and sacituzumab govitecan, which are now used in HER2-positive and HER2-low breast cancer. ADCs represent a major advance in precision oncology. New frontier in targeted therapy is the development of protein degraders, such as PROTACs and degrader antibody conjugates. Unlike traditional inhibitors that simply block a protein, these molecules tag the target for complete destruction by the cell's own disposal system. By eliminating the protein entirely, they may overcome resistance seen with older drugs. This is an emerging field, but it holds great promise for future cancer treatment. Targeted therapy is advancing rapidly, with several new FDA approvals in 2026. Capivasertib in combination with abiraterone and prednisone was approved for PTE-indeficient prostate cancer, marking the first targeted therapy for this biomarker-defined group. Vepdegestrant was approved for ER-positive, HER2-negative, ESR1-mutated advanced breast cancer. Gedatolisib and expanded indications for selpercatinib and zidesamtinib reflect the fast pace of biomarker-driven treatment evolution. Staying up to date with these changes is essential for optimal cancer care. To summarize the difference, chemotherapy broadly kills all rapidly dividing cells, which is why it affects hair follicles, bone marrow, and the GI lining, causing significant side effects. Targeted therapy, on the other hand, interferes specifically with molecules that cancer cells depend on for growth and survival. While targeted therapy doesn't eliminate side effects entirely, cardiotoxicity, bleeding, and skin reactions can still occur. The toxicity profile is more selective and often less severe than with classic chemotherapy. Let's recap the essentials. Targeted therapy means precision, disrupting the specific molecular pathways that cancer cells rely on. The major classes include tyrosine kinase inhibitors, monoclonal antibodies, angiogenesis inhibitors, proteasome inhibitors, and immunomodulatory drugs. Resistance can still develop, as seen with the T315I mutation in CML. The field is rapidly evolving, with antibody-drug conjugates and protein degraders leading the next wave of innovation. Staying informed is key to understanding and benefiting from these advances. That wraps up our deep dive into targeted therapy. If this video helped clarify the topic, be sure to subscribe so you don't miss our next breakdown. Remember, this channel is for educational purposes only and isn't a substitute for professional medical advice. Thanks for watching Onco-Verse, and stay tuned for more oncology insights in our upcoming videos. Traditional chemotherapy has been the backbone of cancer treatment for decades. It works by targeting all rapidly dividing cells in the body, not just cancer cells. This approach can be effective, but it also leads to significant side effects, including hair loss, bone marrow suppression, and gastrointestinal issues. The lack of selectivity is what makes chemotherapy both powerful and challenging for patients. Understanding this helps highlight why targeted therapy is such a significant advancement. Cancer cells often have unique molecular features that distinguish them from normal cells. These features can include mutated proteins, overexpressed receptors, or abnormal signaling pathways. Targeted therapies are designed to exploit these differences, allowing for more precise attacks on cancer cells while sparing healthy tissue. This molecular focus is what sets targeted therapy apart from older treatment methods. Development of targeted therapies has transformed oncology drug research. Scientists now focus on identifying specific molecular targets and designing drugs to interact with them. This approach has led to a wave of new treatments that are more effective and less toxic than traditional chemotherapy. Ongoing research continues to uncover new targets and refine existing therapies, making oncology one of the most dynamic fields in medicine. Personalized medicine is an emerging concept in cancer care, where treatments are tailored to the individual's unique genetic and molecular profile. Targeted therapies are a key part of this approach, as they can be matched to specific mutations or biomarkers found in a patient's tumor. This personalized strategy increases the likelihood of treatment success and minimizes unnecessary side effects. While targeted therapies are more selective than chemotherapy, they are not without side effects. Common issues include skin rashes, diarrhea, fatigue, and in some cases heart or liver toxicity. The side effect profile depends on the specific drug and its target. Monitoring and managing these effects is an important part of patient care, ensuring that the benefits of treatment outweigh the risks. Cancer cells are adaptable and can develop resistance to targeted therapies over time. This can happen through mutations in the drug's target, activation of alternative pathways, or increased drug efflux. Understanding these resistance mechanisms is essential for developing new drugs and combination strategies that can overcome or delay resistance, keeping treatment effective for longer. Future of oncology is bright, with ongoing advances in targeted therapy, immunotherapy, and personalized medicine. Researchers are exploring new drug classes, combination regimens, and innovative delivery methods. The goal is to make cancer treatment more effective, less toxic, and tailored to each patient's unique needs. Staying informed about these developments is crucial for both clinicians and patients. Summary: targeted therapy represents a major leap forward in cancer treatment, offering precision, effectiveness, and a better side effect profile compared to traditional chemotherapy. As research continues, we can expect even more breakthroughs, including new drug approvals, better resistance management, and more personalized approaches. The fight against cancer is evolving rapidly, and targeted therapy is at the forefront of this revolution.